very popular, and I think on popular demand, we were able to bring it back this year with the usual changes. Try to keep the course up to date and advanced. So try and bring in what are the latest things that are happening. So it's aptly labeled Confusions, Concerns, and Changing Paradigms. And I have a super faculty on this course. We'll start with Dr. Quresh Muscati, who will be telling us whether it is really a dry eye or is it an allergy or an infection. And then we'll go into the management pearls with the choice of choosing the eye drops and other masquerades as to what this cause can mimic or what this disease can mimic. And Dr. Umang Mathur will be dealing with that. And then new paradigms in our understanding, the ocular hydration and homeostasis quotient will be spoken by Dr. Rajesh Sinha. Meibomian gland disease, which is a very underdefined and underdiagnosed condition, will be spoken by Dr. Rajiv Mukherjee. I'll take up the debate around hyperosmolarity and osmoprotection and whether there is any evidence that these things work. And then we have some new things that have happened over the last year or two, which is the availability of ribamipide and of course cyclosporin and now chloroquine, and whether these things are really worth what they promise to be. Before we start this course, we have a pleasant introduction to give. We have a keynote address by none less than Professor Harminder Dua, who is the Chair and Professor of Ophthalmology at the University of Nottingham. He needs no introduction to the Indian Society and Ophthalmologists. He's a world-renowned figure and has numerous publications. His CV, and I was mentioning to him earlier, will go into the full length of the keynote address if I go into that. I'm going to start by requesting him to come up and deliver his keynote address. Thanks very much.
Dry eye has become such a big topic that the Dry Eye Workshop DUES 2 is due to report its conclusions very shortly. It's been delayed. I was on the International Steering Committee of that group, and when you read the publication, which will come out shortly, you will see that it's quite a thick compilation of data on just dry eyes. But for the clinician, is that what we really need, and where do we go with our patients of dry eye amongst the hundreds of other patients that we have? So I have tailored this talk for the clinicians. First of all, sticking with the theme that we've said, confusions. So let's look at this clinical scenario. Patient comes to the hospital and says, "Doctor, my eye is dry." What does the doctor do? He takes a history, examination, tests, investigations, and then calls the patient perhaps back another day, and then, sounding intelligent, says to the patient, "You've got a diagnosis, you have dry eyes." And the patient says, "Yeah, but that's what I told you." So the first question is it a symptom or a diagnosis? And if you look at the nomenclature, all these terms have been used to describe the same or similar conditions. But the really important question is, do they all mean the same thing to all ophthalmologists, and never mind to all patients? So when I say somebody's got Sika syndrome, do you relate to it with what is in my mind? We don't, because we don't know what this condition really is. Is there a separate definition for each of these? But the problem is getting bigger, and there are two reasons why it's getting bigger. One, the society in which we live in has made it the most common condition for which people present to an ophthalmology department. It is also going up, and they say about 50% of the people will have dry eye eventually. Women are more affected than males, and younger age is starting to get more affected, and this is because of the environment, the pollution and the pace of life, the stress, the diet, all those contributing to the younger. But the other main cause why this condition is increasing is the big pharma pressure. There is more money to be made out of dry eye and glaucoma, and now perhaps intravitreal injection, than any other product in ophthalmology. So they are pushing, and the number of treatments that are coming out are going up because more and more they want you to diagnose dry eye and use their products. So one has to be careful about that. So before we start with anything, we know what we are talking about, and that definition, there are two definitions in vogue. One is what was called dysfunctional tear syndrome, with or without clinically evident inflammation. That is the key word, inflammation. And the other DUSE 2 classification, which came later, also has the word inflammation in it and the fact that it relates to hyperosmolarity. But this definition will change in a month or two. So remember that dry eye is an inflammatory disease, both in its etiology and in its effect. So it's a vicious cycle that is set up. Now, how do you classify this? You don't have to go into the complicated classification. It will get you nowhere. Clinically, you see a patient, you ask yourself 3 questions. Is this dry eye with lid margin disease, dry eye without lid margin disease, or dry eye with normal tears but an altered tear distribution? And then if you have time, you can go on and say blepharitis, lid margin disease, anterior or posterior, what is the severity level, and where you can have normal tears with abnormal distribution, like in chalasis, lid malpositions, blink problems, and exposure, etc. So, symptoms. All patients will give you different symptoms. The question here is, are these different symptoms or different ways of expressing the same symptom? Now, no woman in the West will tell me, I've got chili powder in my eyes. But in India, a lot of people say it feels like chili powder in my eyes because they never use chili in their cooking. So they are trying to describe the same symptom in the manner in which they can do best. So there are probably not that many symptoms. But there are a few which overlap with other diseases that we've spoken of today, like the allergic eye disease and blepharitis, itching. But dry eye does cause visual problems. And that's the other point of it. Not only is it inflammatory and symptomatic, it does cause visual aberration and therefore needs to be treated. And just to quickly show you some pictures, all of you know this. There is meibomitis, as you can see in the top one there, this squamous blepharitis, ulcerative blepharitis. In my practice, every year I have 3 or 4 patients of OCP that have been misdiagnosed and treated as dry eye for years before they come to me. And by the time they come to you with phonic shortening, it's usually too late. So keep that in the back of your mind, an underlying systemic condition. Conjunctival chalasis is very common. Very few patients are symptomatic. And if they are symptomatic, then treatment by excision is the best way to go forward. You do your dyes. Now, Rose Bengal is no longer available. Lissamine green serves a good purpose instead of Rose Bengal, and look for staining patterns. And then when you look with fluorescein, look for fine punctate keratitis, coarse punctate keratitis, filaments. The key with fluorescein staining is use 2%, put saline drops, 1 or 2 drops after 1 drop of 2%, wait for a few seconds, let the tear film break up, and only then you'll see the staining. Otherwise, the whole cornea is covered with green water and you don't see behind it. So you have to wait for the tear film to break up, and not just for dry eye, for any fluorescein stain of the cornea. With refractive surgery, a new entity has come up. This is called ocular surface syndrome, also called dry eye, and it is due to nerve problem underlying, can be hypoesthesia or hyper-regeneration of nerves. This is a new concept coming into dry eyes even, increased nerve regeneration and increased nerve sensitivity due to the inflammation. And here you will find that the punctate keratitis is largely central, not the inferior 1/3, responds extremely well to steroids, but you have to keep these going, and probably due to a disruption in the nerve growth factor secretion by the damaged nerves. And then you come to the other extreme of the dry eye spectrum, the really bad cases with keratinization, with Stevens-Johnson, chemical burns, ocular pemphigoid, and so on. So that's the clinical manifestation. Diagnostic tests, we have a few: the tear meniscus level, breakup time, the staining, and Schirmer's. Schirmer's 1 is what I rely on, where you do it without anesthesia. The point here is none of them is pathognomic because a huge overlap between normal and abnormal. Tear hyperosmolarity, which was in the definition of DUSE 1, is probably also not pathognomic. Not all patients have that. But IVCM has come forward. It's very difficult. Not all centers have this kit. But with in vivo confocal microscopy, you can see that the epithelial architecture comes back to normal from dry eye with treatment. You can see here the keratocyte activation in dry eye, which comes back to normal. Even the subbasal plexus, the number of nerves which are more become less, and their tortuosity becomes less. So cyclosporin treatment and other treatments do reduce nerve activity structurally and functionally in dry eye patients. So just to give you a management approach, 1 or 2 key pearls or tips. patient with dry eye with adequate reflex steering. So very important question. Do you cry or when you get tears do you get tears when you're peeling onions? They are very, very unlikely to get serious problems. So reflex steering is a good sign. Then when the symptoms are worse than the signs or there are no signs, pain without stain, corneal hyperesthesia and nerve sprouting is probably the underlying pathology. You have to treat symptoms. When the pain matches the sign, then it's the usual presentation. And when there are very mild symptoms but a lot of signs, those are the serious patients, because there the sensations might be less and can cause serious problems later on. There are a lot of drops. I'm not going to go into which ones to use, but the paradigm here is you can use drops and you can use systemic nutritional support. Start with the drop that is simple and cheap, and then work your way down the list. Despite the theoretical differences in practice, there's not much to choose between the drops. Consider possibility of underlying diseases, treat the inflammation, short course of steroids, and then switch to cyclosporine, protopic, or any other form of non-steroidal anti-inflammatory. Long term, consider using preservative-free drops. Omega-3 is very useful, and then watch out for the new drugs we'll talk about, mucin stimulators, androgens, modify the work environment, and don't forget these lacrimal plugs, both punctal and canalicular plugs are there. There are a whole list of devices you can use, warming, heat, without moisture, with moisture, but also a number of office surgical procedures and operating theater related surgical procedures that you can do, like removing filaments, punctal cautery, etc., for patients with dry eye. Thank you very much.
Thank you very much, Professor Dua. We'd request you to stay on the dais. We've got one small little announcement to make. Actually, over the last year, the Indian Society for Cornea and Keratorefractive Surgery has worked on developing something on meibomian gland disease, which is for distribution to all our members and all the ophthalmologists in India. And we'd be greatly appreciative if you could present this little pen drive with those talks and presentation. Umang, cameras. Umang, come. Umang, please come. Suresh. Congratulations. Thank you. Hi. Good to see you. This has been developed courtesy of Cipla, and it's available at their stall. And we'd be very happy if you can walk across and collect these from them. And it's a lovely 1 hour on meibomian gland disease. We're going to go on with the instruction course, and we'd request Dr. Muscati to give us his talk.
Many times we are faced with a dilemma. You've heard the broad overview of the dry eye disease and its complexities. In clinical practice, especially when we don't have access to so much of investigative material, we have a patient who comes to us with symptoms, and most of the time we can diagnose this dry eye with the ears rather than the eyes. Occasionally we are stuck with whether it is an allergy or an infection or it's dryness, or it's a combination of allergy and dryness or infection and dryness, and how do we manage? So let's run through these things. I have no financial disclosures to make. Let's start with allergy. Allergy is easy when the features are very classical. You lift the lid and you see all those lovely giant papillae over there, or you look at the lid, you look at the bulbar conjunctiva and you see all those lovely spots there. Lovely meaning easy for diagnosis, not lovely for the patient. And so these are telling you that we have got allergy. Patient comes with itching. There is no problem there. Classical infections, we know right from that first slide, is borrowed from my father's time 50 years ago. Conjunctivitis, where the limbus is not involved, the blood vessels are away from the limbus, and there is sticky material coming out from the eye. both eyes are affected, the family is affected. Classical conjunctivitis, usually viral, usually an epidemic, no problem in diagnosis. Classical dry eye, you've already seen some of the pictures from Dr. Harminder Dua with the blepharitis, the mucus collecting at the canthus. If you've done BUT or Shermer's or Rose Bengal, which is still available in our country, or you see the filaments, or the patient gives you history of being a computer geek who spends 15 hours on the computer, or he tells you that his blink, or you can see that the blink is less. So these are classical dry eye. Again, no problem. The issue occurs when all these classical symptoms are not there. What about those who have allergy and dry eye? It's quite common. Go into a careful history taking. Is the patient feeling a burning sensation or a sandy feeling along with the itching? We know that the predominant symptom is itching in an allergy. At the same time, he tells you, or the child tells you, or the mother tells you, that the child gets a lot of burning sensation as well. How do we, so you suspect that this could be a dry eye along with the allergy. Therapeutic trial, you add preservative-free lubricants to his allergy treatment. Is the patient significantly better? If so, then it is a combination. One thing we need to beware of in our urge to treat with lots of medicines in the eye is a keratitis or a conjunctivitis medicamentosa. When you get a patient who has a non-specific inflamed eye, little pinkish, not really angry, little bit of conjunctival edema over there, cornea may or may not take staining, and the patient's symptoms, whatever treatment you give, initially the patient feels better and then it sort of reaches a plateau, or it reduces with the same regime with which he was better. And the patient has a multitude of symptoms. Redness is there, there is some amount of lid swelling, and the patient gets blurring. Now this combination is seen in medicamentosa. You can also see this in any of the other three that I told you. But the cornea does show some amount of staining in a keratitis medicamentosa. There could be epithelial defects. If it's long-standing, there could be dilated vessels which are there. Sometimes you could even get pseudodendrites and disciform sort of stromal infiltrates. So you need to be aware of conjunctivitis and keratitis medicamentosa, especially if the patient has gone doctor shopping. Tips in far as control of infection is concerned. If a so-called infection of the conjunctiva has been treated with topical antibiotics by a colleague, no steroids, topical antibiotics, and it's not shown an improvement in a week or 10 days, or has worsened, suspect conjunctivitis medicamentosa. Just stop the antibiotic drops, replace with lubricants alone, frequent use. Patients should start feeling better within 48 hours, and then you can add surface-acting steroids to the lubricants. What about, this was allergy and infection, then we talked about conjunctivitis medicamentosa. What about dry eye and infection? Many assume that all ocular symptoms of dry eye patients can be alleviated by either increasing the frequency of the lubricants, or adding lubricants, or changing the lubricants. So patient has been to two doctors, they've put him on say CMC, and somebody else has put him on sodium hyaluronate. You think of a third drug which a company fellow came and talked to you, because you assume that everything in dry eye is dry eye. However, dry eye patients are also prone to infections. So avoid treatment on the phone, call the patient in, look for coexisting blepharitis. Unless you treat the blepharitis well, either the meibomitis or the squamous blepharitis, these patients are not going to improve. The particles of the squamous blepharitis often keep going into the eye and causing irritation. A known dry eye patient can present with conjunctivitis also. It's not uncommon. Don't overdo the topical antibiotic. You don't have to go in for higher generation. Go for the minimum 4 times to 6 times a day. Short course is sufficient, but continue with aggressive treatment of the lubricants at the same time. And please understand that topical antibiotics should be stopped abruptly. There is no such thing as a tapering of antibiotics. Continue the lubricants in a dry eye patient. What about the third combination, allergy and infection? Kids often rub their eyes with dirty fingers. They're not the most hygienic of individuals that you can have. So suspect coexisting infection if the patient or the parent tells you that the eye discharge is different. You see, every kid with allergy has got some amount of discharge which is typical for that kid. The mother is alert. She knows when she tells you that the discharge is now looking different. Trust them, call the patient to the office, treat as a coexisting infection, If besides the papillae which are inflamed, the rest of the conjunctiva is also inflamed, short course of again topical antibiotics with an abrupt stop and let the allergy treatment continue. So avoid aggressive steroid treatment in diagnostic dilemmas. Just because you're not sure whether it's a combination, please don't load the patient with steroids. They only suppress all symptoms and sometimes new infections come in on stoppage. So avoid shotgun therapy with multiple anti-infective. Time and again we get patients who've been on antifungal, antiviral, antibiotics at the same time. These patients will end up with keratitis medicamentosa sooner or later. So to conclude, allergy plus dry eye, infection plus dry eye, and allergy plus infection all can coexist. We need to learn to recognize and treat these. Avoid telephonic diagnosis and treatment, especially chronic dry eye patients who ring you up. You say just increase the dose to every 15 minutes. Don't do that. Don't overdo anti-infective treatments. Do not taper topical antibiotics and beware of conjunctivitis medicamentosa. Thank you so much.
Thank you very much, Quresh. I think what we're going to do is, since it's going to be, all the talks are more or less linked, I'd be very happy if you can note down your questions, and then we'll have 15, maybe hopefully 20 minutes towards the end, where we can then discuss those, and if anyone has any doubts or any comments or clarifications, we can address those. Umang?
Thank you, Dr. Rishi. It's always a little daunting to speak after Professor Dua and Dr. Muscati. So I don't want to be repetitive, so I'll run through a few of my slides. When we're treating dry eye, it's very important to find the underlying cause for it. It's not just putting lubricating drops in the eye. And as has been mentioned, don't miss the lids. Meibomitis, blepharitis, very commonly missed. There could be systemic problems like rheumatoid arthritis. Very often in India, the ophthalmologist is the first person to diagnose rheumatoid arthritis. Oh my, I didn't realize that. Okay, yeah. Acne also on Indian skin is not easy to discern, but we do get rosacea here, and it comes with Meibomian gland disease. So systemic problems need systemic treatment, and that should not be ignored. And as has been mentioned in the first talk, LASIK is another reason for having dry eye. Now, once you've taken care of that, the next thing is to supplement the eyes with tears, artificial tears. Now, the question is what to choose from. Almost every company has at least 4 different types of lubricants, and for some reason they have 4 different representatives coming to talk about each of those products. Now, the goal of using a tear substitute is to increase the humidity of the ocular surface, improve lubrication. It may contribute to improving vision. Dry eye, especially when you have a lot of staining, can really impair your vision. Now, the limitation that we have with the artificial tears is that normal tears is very complex. It's made of several things like water, salts, proteins, lipids. It has those 3 layers. Artificial tears are delivered intermittently, while tears with every blink constantly are coming onto the surface. Now, the tears, what we have in the bottle, has an active ingredient, and then there are inactive ingredients that we'll just talk about. Now, the main ingredients that we have are dextran, HPMC, glycerin. We also have polyethylene glycol, propylene glycol, hyaluronic acid. These are the active ingredients, and these are some of the inactive things like preservators, the pH, viscosity, tonicity, electrocytes that also influence the what we get on the eye with the artificial tears. It's important to look at the preservators, especially when you're putting it more than 4 times a day. And when you're putting it frequently for a length of time, it's better to avoid some of the preservators that can cause toxicity. We have the preservators would cause disruption of the tear film, will affect the tear breakup time, damage the goblet cells and the epithelial surface. The preservatives by themselves will cause worsening of the dry eye. We know that that happens with a lot of glaucoma medications. So there are disappearing preservatives that we have that when put on the eye, the preservative disappears. And then you have the single-use units which have no preservative. So especially when you need it very frequently, it's best to have the totally preservative-free lubricants. However, they come with a cost, and they are not the most convenient. All dry eye states will increase the tear osmolarity, and that causes problems on the surface. The artificial tears will help in reducing the tear osmolarity, and that helps in keeping the ocular surface in a better health. For preservation of the tears in the bottle, most of the manufacturers keep a slightly acidic solution. However, for comfort on the surface, we prefer to have slightly alkaline constituents in the tear film. And so there's this dilemma, and a balance is required that we keep the surface more comfortable while the manufacturer has to keep the drop in a stable form. Now, if you have a very viscous lubricant, it will stay on the surface longer. However, it comes with a problem of causing blurring of vision. It disturbs blinking. It lumps and causes problems in our vision, and sometimes causes crusting, which tends to stay on the surface on the eyelashes. The electrolytes that we have are sodium, potassium chloride. It play an important role in the osmotic regulation of the extracellular and intracellular spaces. Calcium and magnesium exert a stabilizing role in the cell adhesion. So these are the other constituents that we need in regular tears. So what we have in the market are drops, gels, ointments. Drops are convenient, however, have a shorter retention time. They don't cause that much of blurring. The gels that are available stay a little longer, and so you require less application. The ointments, the oil-based solutions that we have, although stay on the surface longer, but do cause blurring of vision. So trying to make some sense of it, typically the first line we start with something which is not as expensive if it doesn't need to be put very frequently. So the methyl and hydroxypropyl cellulose drops are popular there. If that doesn't work, we can move to things like what we have in the market, like a Sustain or an Optiv, which have slightly better surface properties. And what is coming in the market is a lot of sodium hyaluronate kind of substances, but there are not enough studies to tell whether they really help. But they do stay a little longer on the surface. So which one should we use? And it's sometimes best to be answered by the patient, and the patient would tell, I prefer this over that. I would agree with Dr. Dua that most of the times they all seem to work. It's not very clear which one is better or not. The other things that, and we'll be talking about in the course later, is that you have to decrease inflammation. Pulse steroid therapy followed by cyclosporin helps in controlling the inflammation that controls the dry eye. I won't dwell on it. I think we have talks on that. Tetracyclines, again, help in improving the ocular surface and reducing inflammation. Punctal occlusion and decreasing evaporation, and sometimes For very severe dry eye, moist chamber goggles help. Improving the ambient humidity helps with patients with very severe dry eye. For very severe disease, scleral contact lenses do help. These are lenses in which you can put BSS or even preservative-free artificial tears, and it really helps people with debilitating dry eye. They don't have to put frequent drops once they wear these contact lenses. So for end-stage disease where it's possible to use scleral contact lenses, it's a very important thing in our armamentarium in managing dry eye. I think we'll be talking about stimulation later. These are the newer things that are coming. And so in summary, dry eye can have effect on quality of life. It's very important to look at the patient as a whole. Don't miss the systemic causes of dry eye. Look at the lid margin. Try to find a cause for it. And the topical drops, the lubricants that are available, it's not very clear which is better than the other. It's probably left best to the patient. Start with something which is less expensive. It's to be put very frequently and see what the patient responds to. Okay. The other one, should I continue with that?
Yeah, you can go on to the second part of the talk as well, Umang, and complete that.
So we often, when we talk of dry eye, it's a very routine diagnosis. Almost every other patient coming to our clinic would have dry eye. And one dry eye one feels is as good or bad as the other dry eye. However, among the sheep, we sometimes have the wolf. And we miss out on some other conditions that may be underlying and causing that dry eye. Now, the broad thing that we need to do in the clinic is to, when we've made a diagnosis of dry eye, is are we dealing with aqueous deficiency dry eye or are we dealing with evaporative dry eye? So, like this lady, 50 years old, complains of pain, redness, diminution of vision in her right eye. She gave a history of accidentally putting some sort of a balm in her eye, following which she became very symptomatic with a red eye, and she presents with this corneal abrasion. She was undergoing treatment with a lot of antibiotics and topical drops with no relief. This is how we saw with this epithelial defect, punched out lesion, pretty clean base. What are we dealing with here? When we look at the fellow eye, this is the picture. So are we dealing with just the balm, or the balm was just inciting an underlying problem? On taking further history and examination, we get to know she has multiple small joint pains, morning stiffness for the last 10 years. She had been taking some Ayurvedic medication for the same, with dry mouth off and on. We got her investigated, and surely she was rheumatoid arthritis positive. She needed a tissue adhesive and subsequently healed with systemic medication. There was another patient, 65-year-old male, who underwent cataract surgery elsewhere 20 days back, comes with pain, redness, irritation, and diminution of vision in the left eye. He consulted his ophthalmologist and, thinking of an infection post-cataract surgery, loaded him with a lot of antibiotics and even antifungals. The fellow eye status was an empty socket, and so the patient was very alarmed, and so was the surgeon. The history of this eye had undergone cataract surgery 6 months back, had keratitis, and then underwent evisceration. So again, digging a little deep into the history, why would two eyes respond that way? There must be something systemic underlying. And again, the patient had joint pains for almost 2 years, was not on any medication with dry mouth. He again had rheumatoid arthritis, and that was the cause for the sterile melt. And we know a lot of these conditions get precipitated with intraocular surgery or any kind of trauma. The patient needed systemic medication, initially high-dose steroids, and then we were able to shift him to methotrexate, and with that he scarred with 636 vision. Here's another lady with peripheral ulcerative keratitis, epithelial defect, stromal infiltration, and even scleritis. She was C-ANCA positive, and she diagnosed as Wegener's granulomatosis. With systemic medication on immunosuppression, she stabilized. After 4 months, because of the dense cataract, we took her up for surgery when the eye was quiet on systemic medication. Within 2 weeks of that, she perforated. She had a scleral melt. And so these cases are difficult. They need very good systemic workup and may not respond the way we expect, and one should be very careful in planning surgery in these patients. Severe dry eye because of poor sensations on the cornea. In fact, it's said that that's the worst form of dry eye if you don't have corneal sensations, because the reflex arc for tearing gets disturbed. So neurotrophic ulcers would result when we have absence of corneal sensations. Here's a gentleman who underwent a cataract surgery and a VR surgery, and post that the redness and discomfort continued. On examination of the lid margin, you can see there is severe meibomian gland disease. This is something which is not very easily seen on our Indian skin, but the patient had these small eruptions on the face. He did give a history of turning a little red in sunlight. The patient had rosacea. It's much more easy when an expatriate walks into our clinic. There it's much easier to discern. Here's another patient who comes with recurrent chalacea, and this is because of the recurrent meibomian gland disease that they have, underlying rosacea. The quick one, the last one, is it a cause or effect? This patient comes into the clinic, has been getting treatment with a lot of lubrication, a lot of irritation, unable to open the eye. Essentially, she has essential blepharospasm, where the tear film becomes unstable. So oftentimes we feel it's the irritation causes spasm, but it could be the other way around. It is, once you give Botox, the symptoms go away. Maybe I should end. Yeah, this is the last one. This 36-year-old male presents with a history of redness and photophobia of 3 months, was hospitalized, had some duodenal, esophageal, and stomach ulcers, history of drug abuse and alcohol. He comes with a perforation. We do a therapeutic keratoplasty. The epithelium does not heal. What are we dealing with? Is it one of those ocular cicatricial conditions? But here it was because of malabsorption in an adult and with vitamin A deficiency. So that sometimes that a rare condition like that can also come, and given vitamin A supplements helped in treating this patient. Thank you.
Thank you, Umang. As Dr. Rajesh sets up his talk on post-surgical ocular homeostasis, thank you so much for bringing out these masquerades. And I think it's the ocular surface disease pretty much encompasses such a wide variety of presentations that it's sometimes a challenge. It's not just straightforward putting of lubricants to get the best possible outcomes. Rajesh.
Thanks, Dr. Rishi, for including me in this course. A very good morning to all of you. I'll be talking about the post-surgical ocular homeostasis. Now, whenever we do a surgery, what are the issues that come up after a successful surgery? What we ophthalmologists want, we want a good visual outcome. And if we have done a cataract surgery, we want the IOL to be absolutely well-centered. If we have done a retinal surgery, we want the retina to be absolutely flat, well-settled. If we have done a glaucoma surgery, we want good, normal, controlled IOP with a nice bleb. And of course, if we have done a refractive surgery, we want a nice LASIK flap without a stria, without any problem. But the patient is more comfortable when he has better comfort. And many a times, in spite of having a very good 6/6 visual acuity, well-settled retina, nice bleb, good control of IOP, everything is fine, but the patient has some symptoms like irritation, redness, foreign body sensation, and many times these days, since we have attained that thing that we can achieve 6/6 vision in most of our patients, then the patient has other complaints like irritation, foreign body sensation, and what to do for that? Well, the reasons for these symptoms are disturbed ocular surface homeostasis, and which means that there is inadequate ocular surface hydration because of various reasons after these surgeries. Let's see an example. If we have done a LASIK surgery, then we create a flap. When we create a flap, we cut the nerves, as Professor Dua was also mentioning, that there's denervation, and it takes time for the nerves to regenerate. Now, during this period, what happens is that the sensation to the brain and through which the lacrimal glands is reduced, and that's why we have less tear secretion. This is the tear secretion neuronal loop, as you can see, and from here, from the cornea, the sensation goes to the brain, and from there it goes to the lacrimal gland, and then it comes back. The tears come to the ocular surface. And if there's any damage in between, then it can cause a lot of problems, and it can cause absolute deficiency of tear film. Now, this was one survey that was conducted amongst the dissatisfied patients after LASIK. And they found out that 1 out of 5 individuals were dissatisfied because of the symptoms related to dry eye. Now, a lot of studies have been done even after cataract surgery that the patients do complain of symptoms related to dry eye, related to ocular surface disorder. And there are various factors. Now, some of these patients are old, they are predisposed per se for meibomian gland dysfunction, for ocular surface problems. Some of these are perimenopausal females. Some have these MGDs, some are having coexisting glaucoma, because having glaucoma also is, the occurrence is mostly at that age, something around 50s, 60s, most of these open-angle glaucomas, and they are on anti-glaucoma medication. So they are all predisposed to develop symptoms related to dry eye. And cataract surgery per se can also cause symptoms related to dry eye, because you create an incision, so you cut the nerves. Then you, because of all these, there can be altered corneal curvature, so the breakup time is reduced. Then, of course, you also want the patient to have absolutely 6/6 vision, so you want to do LRIs, you want to do corneal incisions, and all these can cause damage to the nerves and reduce the tear secretion. Now, coming to glaucoma surgery, what happens after glaucoma surgery? These patients, as such, are elderly. Many of these, I'm not talking about the congenital glaucomas, but all these open-angle glaucomas, etc. They are predisposed to meibomian gland dysfunction, to ocular surface disorder, and they are on anti-glaucoma medication, which further predisposes them to these symptoms related to dry eye. Then when you do surgery and you use antimitotic agents, then it can have surface toxicity. There is loss of limbal stem cells, and sometimes a large overhanging bleb can cause SPKs or Dillon just adjacent to the bleb. And that can create problems, that can create symptoms related to disturbed ocular surface. After retinal surgery, a lot of studies have been done now these days. Studies are coming up with ocular surface problems after retinal surgery, because many a times we debride the corneal epithelium while doing retinal surgery, and this epithelial healing is quite delayed, because many times they are for diabetic vitrectomies, and per se, as such also many times, because of the drug toxicity, the epithelial healing is delayed and they have symptoms related to dry eye. There is goblet cell damage, there is conjunctival damage because of the manipulations. And a couple of studies have come up regarding phototoxicity of light, microscope light, to the ocular surface. And that can also result in ocular surface problems. Now, this is one study which was in vivo confocal microscopic study on corneal wound healing after corneal epithelial debridement in diabetic vitrectomy. And they found out, as you can see there, that the corneal epithelial defects were found in 22.8% of eyes at 2 weeks and 5.4% of eyes at 1 month after surgery. And they somehow correlated with the injection of silicone oil and with the use of large buccal with the delayed epithelial healing. And of course, as I mentioned, that there are various drugs that are used which have the molecule per se can cause toxicity, the preservatives can cause toxicity, and they can all have a compounding factor on the symptoms related to dry eye. This is an upcoming terminology. We all are aware about all these factors, but this terminology is coming up to objectively quantify the severity of ocular surface disorder, and that is ocular homeostasis and hydration quotient, as OHHQ, and in which the parameters that favor the ocular surface are on the numerator, and the parameters which don't favor the ocular surface, which have detrimental effect, are in the denominator. So if the value of OHHQ is high, this means that the patient is having a better ocular surface, but if the value of OHHQ is low, then the patient can have a disturbed ocular surface. As far as management is concerned, a lot of all these things have been discussed, so I won't go into too much of details. But yes, preservative-free or disintegratable preservatives with lubricating polymers are the ones that are mainstay. After any surgery, like after LASIK surgery, we have to use it for nearly 6 months to sometimes 1 year. There was one study which showed that the nerve regeneration after LASIK, it comes to near complete after 5 years, but after 3 years, most of the nerves, they regenerate more than 90%. At the end of 1 year, the nerve regeneration is enough that the patient is less symptomatic. So we have to use lubricants after LASIK for nearly 6 months to 1 year. Some of the polymers are there. You can choose any polymer depending upon your own experience. And anti-inflammatory agents have been emphasized by Dr. Mang, Professor Dua, and Dr. Muscati as well. So anti-inflammatory agents are really used, required, because there is subtle ocular surface inflammation in these cases. So to conclude, there can be situations of disturbed ocular surface homeostasis after any surgery, like cataract surgery or refractive or glaucoma or retinal surgery. The treatment, as we have been doing, all these patients, they do require, apart from the routine postoperative treatment, they do require ocular surface support in the form of preservative-free lubricants, anti-inflammatory agents like topical cyclosporine, topical steroid, or sometimes omega-3 fatty acids as well. Thank you very much.
The next talk.
Yeah, go ahead. Sorry, Rajesh.
The next talk. Thank you, Rajesh. The next talk will be by Dr. Rishi, a very senior corneal surgeon from Delhi. And Dr. Rishi, please carry on, I think.
Thanks. Thanks, Rajesh, and rest of the panel. Good morning again. So I'm going to go on and take this talk and talk about newer concepts. So they're not new anymore. I mean, it's about 10 years old now, but it's still gradually percolating into daily practice. And that is this question about hyperosmolarity and whether osmoprotection makes a difference. And hopefully after these next 7 or 8 minutes, you'll have a fairer understanding of how these things have been derived and what is the evidence to suggest that this thing really works. So we know now that dry eye is accompanied by an increase in osmolarity and inflammation of the ocular surface. Professor Dua elaborated on that. And this starts fairly early in the disease. And we have a new definition now of dry eye, which was enunciated in 2007, wherein the hyperosmolarity and inflammation of the ocular surface have become integral to the part of the definition itself. Now, what is osmosis and what is osmolarity? It is important to understand these concepts. So, taking you back to your school days, it's the proportion of water really on both sides of a semi-permeable membrane that causes isotonicity or isoosmolarity. And when this gets disturbed, then the cells tend to lose water because there's a hypertonic environment, and they shrink because of the loss of water that happens within the cell. So when the tear film is healthy, it maintains a constant osmolarity, and when it's dry, either as a result of high evaporation or because there isn't sufficient water, this raises the osmolarity and upsets the isotonic balance between the tear film and the intracellular fluids. In the healthy eye, this range is between 296 and 302 milliosmoles, which is the same as blood. But in dry eye disease, this goes up substantially, and the value is generically above 316 milliosmoles. But these spikes on the ocular surface, exactly where these cells are, because all these tests are done with meniscus fluid, and they're not actually being done on the ocular surface as such. So it's postulated that the osmolarities there are at a much higher level than they are found in the meniscus. So what happens is a compensatory mechanism comes in. You must have seen this animation in the past, wherein this dehydrated cell shrinks, but the cell can't remain in a shrunk form. So what does it do? It does what it calls a regulatory volume intake. It pulls in water, restores its shape, but along with the water come in the salts. And what do these salts do? Like sodium, potassium, and so on. They interfere with the cell metabolism. They decrease the cell function because there's now hyperkalemia, there's hypernatremia, and there's hypermagnesemia, and all of that, and that produces cell damage and death. And this is how apoptosis happens in a hyperosmolar state. This also sets up a vicious cycle of which tear hyperosmolarity is a part, tear instability and inflammation is a part, and leading to apoptosis. Now this ocular surface damage, as I said earlier, starts to happen fairly early. Within the first 2 to 3 days of exposure to hyperosmolar stress, there's acute epithelial disease, and then it goes on to chronic ocular damage within a week or 10 days, wherein the inflammatory components of the cascade start to come in and start to further amplify the whole process of dry eye disease. Various organs in the body are subjected to hyperosmolar stress, and like the kidneys and so on, but they have the capacity to produce or import what we call compatible solutes. Now, what are compatible solutes? They are non-ionic organic compounds that can build intracellular osmotic strength without damaging proteins. That means they don't interfere in the metabolism of the cell. However, they bring in water. So what they actually are able to do is to give what we call osmoprotection. So now going back to the same animation, if you look at the normal cell, the shrinkage, the regulatory volume intake, and the cell apoptosis and death, now a new mechanism can be brought in, which is called the regulatory volume intake because of compatible solute intake. And this restores cell volume without impacting cell metabolism. And this is where the role of osmoprotection comes in. And these osmoprotectants are taken up by the cells, they restore cell volume, and they stabilize the protein function. These are the naturally occurring compatible solutes which are found in nature. There's a whole list here. Polyols, amino acids, L-carnitine, which is a methylamine, small carbohydrates, urea. They're all there in various species wherein the hyperosmolar stresses can be minimized. So how do we protect against hyperosmolarity? The goal is to improve the patient's quality of life and symptoms by re-establishing homeostasis, and to prevent the patient from either entering the vicious circle or promoting the exit from it. So how do you prevent entry? One can look at the causative factors such as systemic disease, contact lens use, environmental factors, etc. Or you can promote the exit, which involves addressing the central mechanisms such as the tear film instability, inflammation, and tear hyperosmolarity. So there's an expanding pool of data that now suggests that the osmoprotective effect on hyperosmolar damage actually takes place. And these are some of the kinetic properties of some of these compatible solutes which are different and enter into the cell at different rates and carry the water with them. And it is a proper combination of the presence of these compatible solutes that works best to increase the overall protection inside the eye. So what are the evidences that suggest that there is hyperosmolar loss and how osmoprotectants work? So here's a study which suggested that when there is elevated osmolarity, there's an increased activation of certain MAP kinases or enzymes, and when osmoprotectants are added to that incubation medium, there's a significant decrease in the ratios of the phosphorylated to the total MAP kinases, thereby suggesting that there is less activation of these enzymes. Similarly, the matrix metalloproteinases, which are induced by hyperosmolarity, suggest that with when you switch them into a hyperosmotic medium which contains these osmoprotectants, there's a better control. So here's the suppressive effect of L-carnitine and erythritol being shown in this slide on 3 of these MMPs, MMP 7, 3, and 13. And clinical evidences also exist wherein there are presentations and publications showing the comparisons between osmotically regulated formulations versus the simple what we call stabilizing or the non those lubricants that work only on the ocular surface. And you can see the OSDI scores and the number of drops being required per day going down in those who are receiving osmoprotectants. A large study done in Germany showed that there was improvement which was across the board in patients who were using these medications which contained osmoprotectants versus those that were not. Both the tear breakup time and the OSDI scores went down. And so there's limited impact of the normal drugs, but those that have electrolyte composition and those that have osmoprotectants work better. There are more evidences that are coming in which suggests that there is a role of all these things, like L-carnitine in protecting the ocular surface. I mentioned that as one of the osmoprotectants, and we know that in dry eye subjects, the L-carnitine levels in the ocular surface tear film is much lower, and it is this that produces the problem. So to summarize, dry eye is a significant problem with an ocular surface damage occurring even in the presence of a normal tear film, and this is mediated by hyperosmolarity, which is a key mechanism in the evolution of dry eye. The cells utilize short-term and long-term regulatory mechanisms to maintain osmotic balance. Hypotonic solutions provide only very transient relief. Compatible solutes help regulate the osmolar balance and restore the tear film osmolarity and protect from environmental stress. And there's mounting clinical evidence of the beneficial effects of these tear substitutes, and compatible solutes with different kinetic properties in the formulation probably have the best solution that we can offer. So thank you very much, and I'd like to invite you to the forthcoming Delhi Ophthalmic Society conference, which is coming up on the 7th to the 9th of April, and you're all very welcome to join us there. Thank you.
Thanks, Dr. Rishi. Now I invite Dr. Rajiv Mukherjee for his talk on meibomian gland dysfunction.
Very good morning, and it's really heartening to see so many people on the first day, first show of AIOC. And thank you, Dr. Rishi, for having me as part of the course. I'll be talking about meibomian gland dysfunction. I'll yet to see how much justice I can do with this topic, as it's a good half an hour long topic, but I'm condensing it to 7 minutes. So I'll be going very fast. In case we have anything to discuss, maybe we can do it in the question answer session. Well, let's look at this 43-year-old female suffering with red eye irritation since the last 2 years. The dermatologist had opined that she has acne rosacea, and she had been visiting numerous ophthalmologists, at least 8 of them, before she came to me. Looking at her lids, I could see that there were telangiectatic vessels in the posterior lid margin, and they were plugged and obstructed meibomian gland openings, and there was a component of dry eye which is very evident on this slide. The diagnosis was very clear. It was meibomian gland dysfunction, and had this patient been managed very well and properly and in time, this patient would not have required so many visits to so many different ophthalmologists. The incidence of meibomian gland dysfunction varies throughout the world. It generally is up to 60% and very high in the West. But in India, in certain studies, it's shown to be 30 to 54% incidence. The pathophysiology is basically hyperkeratinization of the meibomian gland openings and increased viscosity of the meibomian gland contents. And these are basically triggered by androgen deficiency, that is testosterone deficiency, estrogen supplementation like HRT in women, progesterone supplementation, treatment of acne rosacea by isotretinoin actually enhances or makes the disease condition worse. Increased age is a major risk factor. The older the patient, the more the incidence of MGD. And contact lens use obviously is also accelerates the condition. If we look at the risk factors, the ophthalmic risk factors would be quite linked to the pathophysiologic conditions that I just mentioned. If you see anterior blepharitis, contact lens wear, Demodex infestation of the eyelids, and dry eye disease, these are the ocular ophthalmic manifestations. The systemic factors would be androgen deficiency, menopause, aging, Sjogren's syndrome, cholesterol levels being high, psoriasis, atopy, acne rosacea, hypertension, rather patients on antihypertensive medications, prostatic hyperplasia, and medicines like anti-androgen treatment, BPH treatment, prostate hypertrophy treatment, hormone HRT hormone replacement therapy, estrogen treatment, antihistaminic patients with antihistaminic treatments on antidepressants, and patients on retinoids. These are all patients that would actually have a very high risk of having MGD. Well, what does a normal meibomian secretion look like? It's actually a small clear oil droplet. But if you look at this particular next slide, just a second, we would be seeing two things in the next slide. I mean, just taking time to load it up. In the meantime, I'll just go through it. When we are evaluating a patient of MGD, we look at two things. When we press the lids, is the secretion expressible? And in case it is expressible, what is the quality of the secretion that is coming out? So it's divided into various stages and grades. And you can see over there grade 0 being the clear oil droplet that you see. It becomes slightly cloudy. Grade 1 with the condition worsening, it becomes cloudy with debris. And you have thick toothpaste-like secretions in the grade 3 category. The clinical features might be thickening of lid margins, rounding of posterior lid margin. You can see hyperkeratinization of the orifices on the bottom right. You can see vascularized lid margin. You can see telangiectatic vasculature on the lid margins. You can have notches and ridges on the lid margin. This is basically due to tissue absorption because of chronic inflammatory changes that you see in these patients at the level of the Meibomian glands. And you can have epithelial ridging because of mucosal absorption. There is anterior migration of the mucocutaneous junction. And there is also retroplacement of Meibomian gland orifices, which is a classical sign seen in cicatricial Meibomian gland dysfunction. Associated conditions might be anterior blepharitis, eyelash malposition, Demodex anterior blepharitis, as you can see here. The pathognomonic sign, as you can see in the Demodex blepharitis, is the cylindrical dandruff, classically seen here. The diagnostics are available, in fact, with everybody. We don't realize it. Doing a mammography is not very difficult. It might seem that we don't have the systems or the machines to do that. Take all your patients onto an autorefractor or an OCT, invert their eyelid and try to see them. You will see these Meibomian glands very, very, very clearly. Trust me. Try that with your patients next time. The normal morphology in mebiography is grape-like clusters that you can see on the slide on your left side. The ducts and orifices are hyperluminescent, whereas the acini are hypo. You can see on your right there's an area of Meibomian gland dropout, and these are usually irreversible. So we need to treat these patients very aggressively, diagnose them early, and treat them properly. Lipid layer interferometry, another thing. I don't think we have all access to this particular technology. This actually lets us know the thickness of the lipid layer. It is said that if your lipid layer is 70-75 microns thick, you have a very healthy lipid layer, and evaporative dry eye conditions might be not so common in you. The goal of the treatment is to improve the Meibomian gland secretion, bring about a normal stability of the tear film, and restrict the ocular surface damage. The mainstay of treatment is application of heat, that is warming up of the Meibomian glands so that the contents of a Meibomian gland melt, and there's a mechanical massage which is also goes in conjunction with the heating of the Meibomian glands, thereby expressing the abnormal Meibomian gland secretions. And eyelid hygiene with hypoallergenic soap bars or diluted infant shampoos are also very helpful in these cases. What has been recently being talked about is the LipoFlow system, doing the same thing in a very controlled manner with no pressure on the ocular surface of the cornea. It is a regulated way of heating the tarsus and thereby melting the Meibomian secretion and applying pulse pressure on the tarsal plate, thereby expressing the Meibomian content. Artificial tear supplementation is very important because it rinses the toxins and the debris from the ocular surface, reduces the tear hyperosmolarity, and reduces the friction on the ocular surface. One of the things that has been tried is phospholipid sprays. One of the things that has been tried is phospholipid sprays. This is what the patient actually sprays with their eyelids closed, and because of the body temperature, these phospholipids melt and they kind of coat your ocular surface and bring about a healthy balance to your tear film, providing it a lipid layer. Topical azithromycin is one of the mainstays of treatment, 1% given twice a day for the first 2 days and then once a day for the next at least 6 to 8 weeks. What it does is it's not used as an anti-infective agent, but rather because of its anti-inflammatory and immune modulating properties. So basically azithromycin being used in this condition is not because of its anti-infective properties, but more because of its inflammatory properties. We seriously need to reduce the bacterial lipase amount in the Meibomian glands, and the way to do it is to give oral doxycycline 100 milligrams twice a day, or maybe minocycline once a day of 100 milligrams. This is forced medium expression, something that is being done with more than 80 years in our physician's office. What we do is take up these patients and apply pressure on the tarsal plates. There are various instruments available. You can use your thumb, you can use a collagen clamp. There are multiple ways to do it, but the idea is to keep on flushing out the meibomian contents in these cases. Supplementation with omega-3 fatty acids usually helps, but what's more important than giving oral supplements is to educate the patient how to increase the dietary intake of omega-3 fatty acids, as well as to reduce the omega-6 content in their diet, because omega-6 makes it worse. This is a case of intraductal probing, a video taken from, I think we'll, this is intraductal probing by Steve Meskin, and this is a video borrowed from him. You can see what he does is just probes the meibomian glands, and we are hoping for to see the long-term results in these cases. So thank you very much. I think MGD is an underappreciated, underdiagnosed, and undertreated condition. We must, the problem is our PGs are not taught during the training to pick up this disorder. So we must make it a point to press on the lids and try to see the expression and the expressibility and the quality of the meibomian gland secretions to treat these patients much better. Thank you very much.
Are you ready, Quresh? Yeah, please.
Thank you, Rishi, and thank you, Rajiv. This is a relatively new drug. It's been around now since about 1.5 years in India. I have no financial interest, no shares in the company or any other, but it's just something that you need to know that it's one more weapon that we have in our armamentarium. At some point the slides will move. Can somebody help?
From your laptop, or yeah? So the next two speakers are going to be talking about 3 molecules essentially, which have started to help us in our treatment, especially in dry eye where there's a significant inflammatory component. One is a ribamipide, Dr. Quresh will be speaking about it, and the other is cyclosporin, which is now well known. It's been almost 20 years or longer. Quresh, slides are on? No.
It's blank here, but...
No, this is from this machine, I think. Can you switch the laptops, please?
Okay. We'll go from there. ये laptop blank है. मैं यहाँ वहाँ पे देख के चलूँगा. Let's not say this is blank, but we'll, in the interest of time, we'll just go on. We know that in dry eye disease, one of the key elements is that there is a huge drop in the goblet cells in dry eye syndrome, and therefore logically anything which can help to increase the goblet cells or at least preserve the goblet cells should be very useful in our armamentarium in dry eye syndrome. And in the entire pathway that was elucidated earlier, the hyperosmolarity, the inflammation, and all these, the pathway, at some point it attacks the goblet cells and causes apoptosis or premature cell death of these goblet cells. And that's one area which is not being treated so far. The immunomodulatory drugs like cyclosporin helps as far as suppressing inflammation is concerned. The drugs with compatible solutes help in reducing the hyperosmolarity, but we need something which will attack the goblet cells, and that is where ribamipide came in quite by accident in Japan. Company called Santen came out, they found that this ribamipide is being used for treating peptic ulcers because it causes a lot of mucin secretion, so it lines the stomach wall and prevents ulceration. And they found that if it's such a lovely mucin secretagogue, maybe it could be used in the eye and they came out with a 2% suspension in Japan by Santen. Then it was copied by the Indian local manufacturers who made it from a suspension to a clear solution. We have, on the ocular surface, we have microvilli, and these serve as a scaffolding to hold the mucin. Mucin is the lowest layer over which the aqueous, over which the lipid is there. So if the foundation stone is not good, then your tears are unstable. And we find that in dry eye, if you look at the map, average number of microvilli go down drastically in dry eye, and the average height of the microvilli also go down. So it's like those iron rods in the cement sheets in the foundations. The rods are stunted and the number of rods are also less. So what does Rebamypide do? It increases proliferation of the goblet cells, and therefore the densities, there are more goblet cells, therefore more microvilli. It increases both the secreted and the membrane-associated mucins, so both the types of mucins, and it prevents damage to microvilli so that they stay alive and tall longer. So in essence, it assures that there is firm adhesion and good stability of the tear film. It's been found in various in vitro studies as well that this does tend to work. It also has an effect of suppressing ocular inflammation like cyclosporin does, and it does antagonize the deleterious effects of TNF alpha on barrier functions. So it's an immunomodulator as well. So it acts at various points on this, chiefly on the goblet cells and microvilli, but all along. That's why it says that it gives 360 degrees benefit to the management of dry eye syndrome. There are several clinical evidences on this. This is a trial in which they did 3 endpoints: fluorescein staining score, the Lissamine green staining score, and the tear breakup time. And they found that all these three improved as early as in 2 weeks, and definitely maintained by 52 weeks or 1 year. The fluorescein corneal score and the Lissamine green corneal score, both of them, or conjunctival score, came down, showing that the dry eye improved. This is the pre and the post that you can see in these. And the breakup time, though it did improve, not that dramatic, it never came to normal, but it did show statistically improved from 2.41 to 3.74 at 52 weeks. Patients felt better with this. Right from 2 weeks downwards, it was significant, and at 52 weeks, the green bars that you can see is that the significant improvement in the symptoms. So it does improve the signs as well as the symptoms. They compared it to sodium hyaluronate, and it showed that it was superior to sodium hyaluronate. And when patients were asked, 2/3 of the patients preferred the Rebamypide to the sodium hyaluronate. It also was found that in difficult to treat conditions like Sjogren's, which have dry eye and dry mouth, even in these conditions, Rebamypide, the dose is, it's 2% given 4 times a day. You can give it for 52 weeks or a year, but don't stop it till at least a month or so. Give it a good trial before you say that it doesn't work. I'm skipping some of these slides just to show you that as a useful side effect, just as you find certain drugs working quite by accident, they found that in the presence of giant papillae and allergic conjunctivitis, where the patients were steroid dependent and nothing else seemed to be working, the addition of the Rebamypide did seem to stunt the papillae and improve this. So it was a useful adjunct. Not that we are saying that it should be used as the only treatment for allergic conjunctivitis, but where nothing except steroids is working, this might make this a steroid-sparing condition. To summarize, therefore, it works in dry eye disease. It also works in allergic conjunctivitis. You remember that it's dose dependent. It's 1 drop, 4 times a day, minimum 4 weeks. Then you can say either it's working or it's not working and ask the patient to continue. It does give dysgeusia or a bad taste in the mouth to about 10% or more. In my series, it is about 20% of my patients where I had to stop. So 1 in 5 patients I have to stop because of the bad taste in the mouth. Otherwise, the treatment is quite well tolerated. It does increase the proliferation of goblet cells, mucin, and it also acts on some of the other parts. So to summarize, it's one more molecule having a definite role in dry eye syndrome, Rebamypide. We need to use it judiciously in helping our dry eye patients. I am a Gujarati, and we have these thalis where you have different foods served, and all of them gives you a balanced meal. So we need to add this into our thali of treatment for dry eye syndrome. Thank you so much.
Thanks, Quresh. As always, bringing in some humor into the presentation. Thank you so much. Rajesh, we're going to have the last talk now, and Rajesh is going to tell us about the other two molecules that are being discussed, cyclosporin and chloroquine.
Yeah, thanks, Dr. Rishi. I would just like to emphasize on this part of the definition by Dry Eye Workshop regarding dry. This definition, it shows that it is the ocular surface disorder or dry eye is accompanied by increased osmolarity, which Dr. Rishi has mentioned, of tear film, and inflammation of the ocular surface. So if there is any inflammation, then you require an anti-inflammatory, and there are various anti-inflammatory that we use in the field of ophthalmology, and of course some of the drugs like immunomodulators like cyclosporin, then of course corticosteroid is there, then we have these tetracyclines, doxycyclines, and omega-3 fatty acid. Now, cyclosporin is now a proven drug with a good anti-inflammatory effect for ocular surface. And there are various mechanisms. These are the markers that are markers related to inflammation, and cyclosporin is a drug which reduces the expression of these markers. So that's how it suppresses the inflammation. There are various studies which have given evidence regarding this, like this study, which is by Kathleen Cunard, which has shown that the inflammatory mediators reduce quite significantly after use of cyclosporin. So cyclosporin prevents T cell activation, it reverses inflammation of ocular surface, it maintains the ocular surface integrity, and it improves the goblet cell health by reducing the inflammation on the ocular surface. Now, it has also been seen in literature, in studies, that it improves the actual value of Schirmer's. It increases the goblet cell density. It reduces the dependence of an individual on tear film. This means that if you are using a lubricant for 4 times or 6 times a day, you may reduce it to maybe 3 times a day. So that is how it is helpful. And as far as its systemic absorption is concerned, the absorption is so minimal because of its concentration, low concentration, that it does not have any systemic side effects. This is one phase 2 study which tried to study the role of cyclosporin in ocular surface, and they found out, and what they did was they used 0.05%, 0.1%, 0.2%, and 0.4% and a vehicle. And they found out, the conclusion of the study was that 0.1% cyclosporin produced the most consistent improvement in objective and subjective endpoints. 0.05% gave the most consistent improvement in patient symptoms. And there was no adverse effect seen with any concentration. So that's why perhaps 0.05 and 0.1% are the formulations that are more commonly, they are the ones that are manufactured by the company. And this is a phase 3 trial which wanted to see the role of cyclosporin and the safety of cyclosporin in humans, and they found out that it is reasonably safe. And it is now an FDA-approved therapy. So cyclosporin helps in a quantitative and qualitative improvement in tear film in terms of improved Schirmer's and improved breakup time. It increases the goblet cell density. It has a proven record, as I said, that it increases its Schirmer's value, and it is safe for use. The problem is that the initiation, the effect starts after at least 6 to 8 weeks after initiation of therapy, so it has to be used on a long-term basis. Now, coming to another polymer which is coming up quite fast these days, although not has been used very frequently, few formulations available, but it is coming up fast because of various reasons, because of some emerging concepts. The basic idea is to target the pathology in ocular surface disorder. And we have seen, literature suggests that there is apoptosis of the ocular surface cells, and that is many times because of the UV rays. So what does UV rays do in dry eye disease? Or what does UV rays do on ocular surface? It inhibits the mitosis. It causes fragmentation of the nuclei. that's why there's apoptosis and there's loosening of the epithelial layer. So all these things are the effects of UV rays, and that's why chloroquine phosphate has come up as a drug. Why? Because it is, we all know that it's a known anti-malarial drug, but in ophthalmology it has been used. It was found in a couple of studies that systemic chloroquine was associated with improvement in dry eye in Sjogren's syndrome. And based on that concept, the topical cyclosporin is now being used. You can see the macrophages and neutrophils, what they do, they release metalloproteinases, they release the interleukins and other inflammatory mediators. So what chloroquine does, it inhibits the release of these metalloproteinases and thereby inhibits the apoptosis. The in vitro studies have shown that it has good photoprotection. It protects the ocular surface from UV rays. There are animal studies which have shown that after exposing the animal eye to UV rays, there was photokeratitis, and then when it was treated with chloroquine, they found out that there are good results. Then they also found out that in animals it was safe, there was no side effects, and then the human study started, and initially it was found out that it was found to be safe in phase 1 studies. Then phase 3 study was done, and they found out that in cases wherein cases who are exposed to UV rays, they have good results in terms of improvement in breakup time, in terms of improvement in Schirmer's value, in terms of lesser staining by these fluorescein and rose Bengal stains, and in terms of improvement of symptoms of dry eye. And they also found out that there was no side effect seen with the use of chloroquine in these eyes. So, in summary, since apoptosis is a major pathogenesis, it's involved in occurrence of dry eye syndrome, and many of these patients are from areas where they are exposed to UV rays. Chloroquine is an upcoming molecule which has shown some promise in preventing and in treating the symptoms related to ocular surface disorder because of exposure to UV rays. Thank you very much.
Thanks very much, Rajesh, for that introduction to chloroquine as well. And we're all familiar with what cyclosporin has been doing for our dry eye patients, and I think we all have patients now with clinical experience on the use of cyclosporin. I'm very happy that Professor Dua has stayed on. Any questions with regards to this? Yes, sir.
Thanks for this content talk on MGD. Yes. Welcome, sir. Please upload. Sir, actually, we just launched a USB flash drive with there are 3 speakers on that. It's an hour-length CD explaining meibomian gland dysfunction in detail. It's available at the CIPLA stall.
That's and collect. But one question: most of the time, symptoms and signs are not matching.
The symptoms would be of evaporative dry eye or ocular surface irritation, but the signs would be more pronounced than the symptoms. Because if you look at the ocular of the meibomian gland opening, you will see vascularization there. You will see plugged orifices there. Once you express the contents, you'll have to see, number 1, are they expressible or not? And number 2, in case they are expressible, what is the quality of the meibium that you're getting? Is it, that clinches the diagnosis. That will tell you what further needs to be done.
When we see pre-operatively patients, the occlusions of ducts are there, even this cream-like paste is there, but no symptoms. Patients say, okay.
Yes, I think this is a dichotomy that we all face, the symptom and sign kind of balance. We don't always get it. Patient complains, we see nothing. And it's the reverse. Sometimes the patient is very happy and we see all sorts of signs. The surface is taking up stain, but the patient has no problems at all. In fact, Dr. Dua highlighted this imbalance very often. And would you have a comment on that, sir?
That's a very important observation, particularly for meibomian gland disease. When you see signs of meibomian gland disease but no symptoms, you're probably seeing your patient in an early stage. And eventually, they may go on to develop symptoms when it might be too late. So you may want to consider simple measures like lid cleaning and some expression and heat treatment, that kind of a thing, which will be helpful to prevent them getting worse. But if they are stable for a long time, you can just watch, but you might be picking up very early disease. The one comment I wanted to make is that it's a very philosophical comment. that dry eye is not a disease, that's why we call it a syndrome. Because there are so many, we're probably treating different things. And the very fact that more and more treatments need to come, each time a new treatment comes, it is better than the previous, and we've learned that for all the previous ones. And I agree with you, you know, the ingredients in your thali, in a Punjabi's thali, you can keep adding more katoris and they will keep on taking it. But the Gujarati's thalis, for every new thing you add, you have to take out an old thing. And which one are you going to take out to keep the balance? And the answer is we don't know. Because that's how this condition and the pressure to treat with different drugs is more. Just one final comment, we forgot to mention tacrolimus. Tacrolimus is the first cousin of cyclosporin, and in Japan they have eye drops of tacrolimus for dry eye as well.
Just one small thing, there is always an overlap between aqueous deficiency and lipid layer deficiency causing evaporative tear loss. So it never occurs in isolation. In most of the cases, there would be a conjunction and a part of each pathogenesis there.
Sir, my main concern is we are seeing pre-operatively. And
Yes.
we are going to operate and then put steroids for months together. So that's why some prophylaxis should be there.
Very true. You have a question, sir?
And
Yeah,
role of steroids, sir, local, dilute, and whatever, if you want to say. With azithromycin.
Role of steroids, we're actually now out of time. So one comment, Quresh, last comment on steroids, and then we'll hand over the mic to...
Yeah, if you're giving cyclosporin, cyclosporin takes a little time before it starts acting, so you can give initially steroids, then taper it down after about 2 weeks or 3 weeks. By that time, the cyclosporin starts acting. For dry eye patients, for meibomitis patients, I don't use the steroids, it's not required.
Yes,
Yes, sir.
last question.
Rajesh, just wanted to know what is the frequency of chloroquine phosphate drops? How many times a day? How
It's-
long it is to be used before you
Yeah.
get the effect? Like
Yeah.
5 years, we need at least a month to a year. How long we use? And the third thing is whether you have any studies comparing cyclosporin and chloroquine phosphate as anti-inflammatory. Any difference or any particular cases where you would prefer or switch over from Restasis or any form of cyclosporin to this?
The chloroquine is 0.03%, that is 0.3 milligram per ml. It is used twice a day for 3 weeks. The effect starts after initiation, after 1 week after initiation of the drug, and continues later on. And as you said, there is a study comparing cyclosporin with chloroquine, and they found out that both have almost similar anti-inflammatory property. And as far as the switching over from cyclosporin to chloroquine is concerned, till date, I think most of the ocular surface people, they are more reliant on cyclosporin because of its long track record, it's FDA approved, everything. Maybe with time we will be able to know whether, with more studies comparing cyclosporin with chloroquine, we may be able to know whether chloroquine will be better anti-inflammatory or cyclosporin.
Right.
Till date, it is cyclosporin which is more preferred drug.
Thank you very much. We'll have to conclude here. You can have the questions later on. We've run out of time for this session. I thank my panel and all the audience, Dr. Rajesh, Quresh, Rajiv, Dr. Umang, Professor Dua specifically for taking his so valuable time out. Thank you, sir.